we'll start a discussion. I'll again take the prerogative of throwing out the first question. We've largely kept the discussion so far on the health policy turf, that is, talking about Medicare, Medicaid, health insurance, hospitals, etc. But I think Emily's points from the very beginning showing the financial disruption that caregiving has, and then almost everybody who's been either sitting at this table or on the screen has talked about the caregivers, but has done so within the context of health policy in a sense. So I'd like to ask a question about, isn't there a lot of room, given those financial disruptions, for thinking about the design of sort of more social insurance related to like paid family leave, making some provisions in the SSDI program for disability, or other such programs to support caregivers financially, so that in fact the stepping forward and playing that role is less financially painful and disrupting than it needs to be, or than it currently is. And so I'd like to get each of the panelists perhaps to respond.
I know there have been a lot of proposals in that regard, but the specifics of any of them I couldn't tell you, and I haven't heard any of them talked about recently, primarily because other kind of priorities relative to child care, for example, have taken priority over that in some of the conversations.
This is Amol. I can comment a couple things on this. So I think, Richard, it's, generally speaking, obviously a great idea. And there's a lot of informal caregiving, and particularly in this population, it becomes fundamentally important to the health and well-being of the patient, the beneficiary in this case. I can articulate a couple of challenges, and this is not to dissuade us from trying to solve these challenges, but I think there's still challenges nonetheless that are worth highlighting. I think number one is just the pure health financing challenge. I think one of the attractions of, generally speaking, using the payment reform models that we made allusion to, I think, in the payment model folks' presentations around ACOs, Medicare Advantage, et cetera, is they're trying to motivate, quote unquote, better health outcomes in a cost-neutral fashion to the government and to the taxpayer. And so I think it's going to just be a question right away. If we're going to finance these additional social services, even if they're in a targeted fashion, where do we pull those extra funds from, and what is the associated, sort of political will attached to that? The second piece that I think is a little bit more philosophical is when we think about social services, and I'm kind of zooming out here for a second, and there's a broad debate. I'm going to connect this to a debate that probably may be an overreach to do so, but in general, I think there's been a lot of interest recently in how do we best provide housing? How do we best provide behavioral and social services to individuals who are at high risk for poor medical outcomes and their families? And I think that, again, this is very well-intentioned and in a lot of ways should be supported, with the cautionary piece that we have to be very careful about medicalizing, in some sense, social services. That if we start to apply a litmus test or a meter to say, is providing this social service worth it, and let's quantify that in terms of the impact on the medical system, then we may in fact be doing a very strong disservice. And so a related question I think that comes out of that is, are we designing a program, or we be proposing a program here that would be very directly related to patients with ADRD, or is this something broader? And accordingly then, that has implications for how we might judge, quote unquote, success or failure, or how we think about financing it.
So thanks. So great question, Richard. And so I guess going back to the health policy space a little bit, one example or something that looks a little bit like what you were describing, at least trying to get some resources to unpaid family caregivers, are some of the Medicaid HCBS consumer self-direction waivers. So that's an example where something, not a broad social insurance scheme, but we have at least some vehicle or mechanism to try to do that. I think it's instructive to look at because it illustrates some of the benefits, but also some of the limitations. So, benefits are, of course, that people are compensated for the tremendously difficult, as Bruce put it, and Emily as well, labor that they are doing. Interestingly, we've heard from a number of states that they've seen kind of more uptake of the consumer self-direction model over the course of the COVID-19 pandemic, as they had people at home and they found it was a very helpful vehicle for them to be able to continue providing care for their loved ones as they were no longer comfortable doing so in institutional settings. But I think the limitation to keep in mind is just basic constraints on also labor supply of unpaid caregivers. So what we also hear is that many consumer self-direction programs can't really adequately reimburse somebody who's a home caregiver for 24/7 care. Also, even if they could, we hear that many family caregivers at a certain point simply can't supply that, especially as Alzheimer's disease progresses, patients have more care needs and more behavioral and psychological symptoms. And so is it offsetting? Is it a potential benefit? Yes, absolutely. It's not going to be an end-all and be-all and solution to all of this. First, because of all of the great issues that Bruce pointed out in terms of how we rely on a waiver system to provide HCBS. It's not even a required component of state Medicaid plans, so it's not universally available. There are just fundamental limits on the amount of labor that even the most dedicated caregiver can supply, and there are other supports that they need, and it may be that they need other home care workers to come in and help, and so we should always be considering mechanisms to make that possible too.
That just reminds me of one sort of peripheral.
Should we get Emily in first?
Pardon?
Emily, do you want to?
Okay, sorry, Emily.
Okay, I would just jump in and say that, there's been a lot of hope that we'll find disease-modifying therapy that can slow or prevent the onset of cognitive impairment. But ultimately, I really don't think that we're going to be able to, cure our way out of needing to care for this population. And what that's ultimately going to take is thinking about this not just as something that we need to intervene in a clinic, but to really recognize the ways in which this is a social challenge, and we need to create not just dementia-friendly healthcare systems, but a dementia-friendly society. And so while I agree that there are issues with how we pay and how we think about what the desired outcomes are, if we're not thinking about this in terms of improving our communities so that they're friendlier, so that we have less stigma and discrimination, so that we really can come up with better narratives of what it means to live with dementia, we are fundamentally failing in this space. And so, I tend to think much, thinking like a disability rights lens, that if we make society better for people with dementia, we should see a lot of benefits accrue. We know that, families with young children, lots of people are caregivers, and lots of people would benefit from, really thoughtfully designed social programs and not just insurance programs.
One of the, I think, unavoidable facts that we've been deliberately or maybe unconsciously hiding from ourselves for a long time, if somebody really needs 24/7 care and there isn't an unpaid family caregiving willing to do it, from a public program point of view, it is cheaper to have that person in a nursing home by a lot than to have them getting round-the-clock in-home care. And I would argue that that suggests that there is an incentive-based payment system, if we're prepared to pay for it, for family caregivers, that we could figure out what 80% of the cost of nursing home care would be for Medicaid eligibles and pay that to the family caregiver. But that really makes the cliff of Medicaid eligibility yet a further problem in the total random inequities associated with so much of these issues.
Good. Do we have anything coming in on the virtually? Okay. I have another one.
Could you turn on your
Sorry, I have another one. I'd like to follow up on this. So we've now heard everybody's views on what's desirable, what's hard, what's not hard. If you decide you wanted to go down this route, either one that Emily suggested or some kind of other social insurance, what do you need to know? What research should NIA be pursuing in order to establish a platform where you could, A, design such a program or abandon it if it's not doable? Well, I was thinking from supporting family caregiving. Everybody's scared?
This is Amol. I can start. I mean, I think I might start to some extent with the last piece of the puzzle rather than the first. And the last piece of the puzzle, I think, would be a demonstration projects where we are allocating resources or allowing groups, whether they're health plans or clinician groups or health systems, to in fact provide funding for caregiver support and test it in a rigorous fashion to ensure that what we're getting out of that, in fact, is meeting family needs, is meeting patient needs, and is also leading to the type of health outcomes that we desire in a longitudinal fashion. I say that's the last thing because I sort of as a clinician, understanding a little bit about the pathway of how patients with ADRD experience their clinical trajectory. This is not something that is a 6-month test that we do and say, aha, we solved it, we're done. This is obviously a multi-year type of project. And so most likely what we need to do to get there, I think, are component areas, as we've seen as part of this workshop. What are the critical clinical care model elements? How does the caregiving piece of this, in fact, function? How does it connect in with the medical enterprise care model? And to some extent, I think we need to test some of the financing approaches around how would we motivate the spending, the payments to the caregivers, and attach to what kind of metrics. I think particularly to the extent that we're mobilizing, say, federal dollars in this direction, there would need to be some assessment of what the value that the sort of health enterprise is getting from that. I don't know. I think I can certainly say for myself that I'm far too unknowledgeable to specify what that kind of model looks like. I think we've seen some of really nice building blocks as part of this workshop to date, but I think those are some steps that we need to move forward in a kind of a reverse engineering process, if you will.
You guys are letting
I'll take a crack. So one thing that I think would be helpful to understand in an area where more research would be helpful is first, appreciating that patients and families have different goals and preferences in terms of where they want to receive care, how they want care delivered, and how that may change over the course of the Alzheimer's disease trajectory. I think a key starting point is first acknowledging that heterogeneity in preferences, and so there may not be a one-size-fits-all for everybody. And so, as a as a basic starting point for first understanding what are some of the kind of universal goals, both for caregivers themselves in terms of their own well-being and outcomes, as something that we ought to be looking at and functioning and measuring, and that ought to be more of a deliberate outcome in our research. But then also, how does that relate to the family member who they're caring from? So I think it would be very interesting to better understand within that trajectory, where is it that things are breaking down so that goals are not aligning. So, in family care settings where really somebody is very committed to having their loved one with dementia remain at home as opposed to entering a nursing home, what are some of the key antecedents that drive the difficulty in making that happen? Is it behavioral and psychological symptoms that they just kind of can't manage? Is it that they really, is it burnout and depression? Is it that they really need labor supply from others in the community because they just cannot provide the 24/7 care? Is it things like housing-related supports for people who maybe don't have as extensive a community network and who are living on their own, as many people with Alzheimer's disease are? And so how do we think about caregiving in the context of that population? And of course, there's already a wealth of information about this, but trying to put it together in order to identify policy actionable places and levers where we can actually intervene to really shift the trajectory, I think would be helpful. So taking an integrated approach into pulling some of those more disparate threads of the literature together to identify potential solutions.
Okay, one more. Oh,
Yeah.
no, do you?
Pete Holman from Brown University. This may be kind of the same question, but I watched early in my career the deinstitutionalization of both developmental disabilities and the mentally ill population. And those facilities were extremely expensive to run, at least in my state. And of course, they gave the state an incredible black eye when you saw the kind of care, which was really no care, that was oftentimes being given to people. So I think if we have, Mr. Vladeck mentioned about the possibility of, people were hoping nursing homes would go away. Well, if they're going to go away, which is not probable, of course, but you'd have to have the alternative. And it seems to me you could do some modeling with someone who's smarter than me and has better Excel skills than I do, that would sort of come up with the idea, is that 80%, is it 70%, sort of the woodworking effect that for every time you provide a service, one person deinstitutionalized, but 4 new people get the service in the community, or is it 2 new people? And we also should do that modeling based upon not looking at where we are today, but comparing where we want to be and where we probably will be from our current system. So if we're saying the only way we're going to provide better nursing home care is to pay people that work in nursing facilities a better wage, well, start right out by building that into the model, that it's going to cost more because of the wage, which is the major cost of a nursing facility, is the wages, and then work from there. So I certainly don't have the answer, but it seems to me that that would be some good questions to ask.
Just a really digressive comment triggered by your examples. We are seeing in New York now, over the last 3 or 4 years, in probably no more than triple digits, but the kids who were deinstitutionalized from Willowbrook, in the paradigmatic example of a hellhole for developmentally disabled kids, being moved out to community residences, as those kids are getting into their 50s and 60s and 70s, their medical problems, including early onset dementia because of their longstanding mental problems, are making it impossible for the community facilities to care adequately for them, and they're ending up in nursing homes. So all of which is to say that all our generalizations notwithstanding, there's just a hell of a lot of multi-dimensional diversity in all of these client populations. And somehow, whatever we figure out moving forward, we've got to make room for A, that diversity, and B, the fact that it's going to evolve over time, so that the diversity in our ADRD population now, which is already a challenge for us, is going to change. Whether it's this way or that way, we don't really know. So that takes a very hard problem and makes it, at least intellectually, even more difficult to try to figure out what to do.
All right, one more for you. So this morning, David's comments raised his theme about scaling, and he offered up a series of examples of what I would call expensive boutique operations. And it seems to me what we need here is figuring out what the right Walmart looks like. And the question is, what do we do? That seems to be the big challenge here, is take the good models, find out what the essential ingredients are, and then scale them up. And how do you do that?
Well, I really am a great believer in the development of institutional models. I mean, I think doctors are educable, nurses are educable, social workers are educable, family caregivers are educable, but coordination is a central problem. And I mean, assuming everybody sort of wants to do the right thing, and knowledge base of how to initially diagnose and then manage, effectively care for somebody with Alzheimer's and other medical problems is a professional education issue. And I think what we need are regionally based resources to take the learnings of the boutiques and translate them into operational information and practices, and lobby for the necessary adjustments in payment policy to make those models more widely accepted.
Yeah, I can offer a couple of thoughts here. So, I think at one point I had given a talk entitled, The Crisis of Scalability in Healthcare. And I think this is in part touching what you're mentioning, Richard, which is oftentimes we find boutique tailored models that work in a very particular setting. And when we go to try to generalize it, we experience, incomplete results, let's call them. This has been called in behavioral science the voltage effect, which is you test it in a controlled setting, you get a huge voltage difference, you get an impact, and then you scale it and you get this voltage drop in the effect size. I think it's a fundamentally challenging piece. I agree with Bruce. I think there's a couple of things that are worth highlighting here. I think one, we have to have innovation that's happening in that micro setting because in particular, I think the intensity of the needs and the unique nature of the needs of this population, I think try to innovate in a highly generalizable scale, at scale fashion is very likely to fail. And so I think we need these pockets of innovation as a way to generate the best models. Then we need a deliberate effort to really truly examine across these different boutique settings, if you will, the elements that are common across them. And I think one of the pieces here that is worth mentioning is the notion, for example, that Emily has injected in this conversation around, can we directly support caregivers? This is something that to some extent is intrinsically tailored naturally to that patient, right? It's it is very different than the way we think about slicing and dicing care models and paying for each component, at least the way we do it in fee-for-service, and trying to find a code for everything. I think the caregivers, the notion of supporting caregivers as part of a broader care model is something that's intrinsically not subject to this kind of death by coding, if you will. And I think that is an advantageous feature that we should recognize, because that does have, to some extent, a natural patient-centeredness and a natural scalability. How it fits into the broader medical, if you will, institution, sort of medical institution, enterprise care model, that part is a more challenging piece that undoubtedly we'll need to test and then hopefully find the common elements of that we can scale.
Thanks. Yeah, I'll offer a couple other thoughts on it. So one is that, a number of the components of evidence-based dementia care models are, and a number of the needs are not all that dissimilar from many other patient populations with serious chronic complex illness. So, one thing that, I would love us to kind of think about in terms of scaling and, here additional, evidence and models would be helpful is, to what extent are some elements of what we've seen in dementia collaborative care models of benefit to broader patient populations, but what are the tweaks that we need around the edges to address the distinctive needs of people with Alzheimer's disease versus people with other intellectual developmental disabilities, or people with behavioral health conditions, or any other range of populations who we care for who tend to have complex medical conditions and long-term care needs. I think this might help us get a little bit at the issue of scaling, because the question is, how do we get a large healthcare delivery organization to take on a model like this and make the investments? And part of it may be that there is scope to serve a broader population of people, not just those with Alzheimer's disease. And so how do we balance the need to do that at scale with also addressing the needs of specific subpopulations? So I think that's one thing that would kind of be helpful in also helping to map out the business proposition. But the other thing I come back to in the scaling conversation is we still tend to very much anchor our discussions around scaling in specific healthcare settings. So how do we scale up, an effective collaborative care model that's based in a geriatric specialty practice or a primary care practice? But we're still, kind of struggling to center the home and the family caregivers, as Emily was pointing to. And so, I think that's where we might need a somewhat different conceptual model of what scaling these models is. It's, we sort of know what the health system or the medical system levers are. But once we get into home-based care, it's very different. To Bruce's point, we do not have an existing system really to scale off of. And so how do we build that, and what does that look like? And, along those lines, I really like Bruce's notion of the regional collaborative centers, because I think that brings in an opportunity to marshal other types of resources to build things from the community up and to bring together components that are outside the medical care system, but that are still kind of critical to supporting these types of models.
Okay, I think that was the last word. Did somebody else? Oh, Terry has the last word.
Well, I wanted to just add more resources to the conversation. The Family Caregiver Alliance is a very strong national organization that has a lot of what I'll call natural experiments going on. The next is the Geriatric Workforce Enhancement Program out of HRSA, where they are dedicated to improving care for older adults through primary care practices. That's another sort of on-the-ground experiment going on. The Veterans Administration, if you read Carolyn Clancy's work, has far exceeded anything we're doing in our other approaches to care. And those reports are incredibly strong. And so the last thing is that the Administration for Community Living, in partnership with the public health system, is doing their regional meetings with Carter Blakey leading that, and Rear Admiral Paul Reed. So there's all these logical places to insert ourselves if we decide to do that.
Thank you, Terry, and I want to thank the panel for incredibly thoughtful and well-prepared presentation. So thanks very much, and we're on a break now.